Sorry, I was muted. This is Brian Lau.
And I'm not sure if I was muted or not, so I'm Matt Callison. Welcome very much. Thank you for coming. Really appreciate it. Here's a good start. We are from AcuSport Education and the Sports Medicine Acupuncture Certification Program. And Brian and I want to present today one piece of the whole, so to speak. So this is going to be about forward shoulder and forward head. And it's a problematic postural position. We jump right into this. Oh, you know what? Thank you very much to the American Acupuncture Council for having us. Really appreciate that. I'm excited to get into this information. There's a lot of great things with it. Let's go ahead and get into the first slide, please. Or the next slide. There we go. All right. Thank you. So forward head and forward shoulder, it's a posture that it seems like it's becoming more and more common with sitting in front of the computer a lot more than we used to, especially during this COVID time. The propensity for the weight of the head to go forward and the shoulders to go forward is really quite great. And the more that we sit in one position, we know that the muscles and the myofascial tissues are going to adapt to that position. So it's a lot easier to get into that forward head and forward shoulder position if we maintain that position for hours and hours throughout the day. Now, it's usually predicated from what's happening in the pelvis. So this is the reason why that we're saying that this is just one piece of the whole. So you have to look at the whole body with this to help a forward head and forward shoulder. But we want to give you some nuggets that have helped us clinically quite a bit to help alleviate some pain. Brian, do you want to say anything before we get in the next slide?
Nah, I think we'll jump right into the next slide.
All right. All right, so with the forward head, an imbalance in this posture cannot counteract the forces of gravity, thereby increasing the stress on the musculoskeletal system and perpetuating the aging process. So you can see that red arrow, that would be the force of gravity as the head is going forward of the plumb line. Let's back up a little bit. The plumb line will be measured from the foot going up to the head. You want the plumb line to be in line with gallbladder 40 at the foot, the middle of the knee, the greater trochanter, the middle of the hip joint, then going up spleen 21 region, into the acromion, the large intestine 15 region, and then the auditory meatus or the small intestine 19 region. So in this case, you can see that this patient's head is forward by probably a good 2.5 inches. So for every inch forward posture, there's an increase of the weight by 10 pounds. Imagine what's happening to the upper thoracic region and the lower cervical region in being elongated and pulling quite a bit, trying to be able to maintain their proper positioning. But in this case, they're really struggling because there's so much weight pulling forward. This can increase the aging process significantly the longer that it ends up lasting. I mean, there's a host of injuries that can occur from forward head and forward shoulder. Brian, let's go ahead and think about this. We've got thoracic outlet syndrome. You've got lower cervical spondylosis in the 40+ age group that's increasing, nerve impingement. What else, Brian, with this forward head?
Muscle tension headaches would be a big one.
Yeah, that's true. Dorsal scapular nerve entrapment could be a big one there. Gosh, acromioclavicular joint strain is something. Sternoclavicular joint strain is there. With the pectoralis minor being in a shortened position and the anterior scalenes being in a shortened position, there's your nerve entrapment sites for thoracic outlet syndrome. So, with this forward shoulder, it goes down the upper extremity chain. The head of the humerus goes. Sorry, go ahead.
Oh, go ahead. Yeah, the one worth mentioning also is the one we're going to be covering more in detail later is a lot of shoulder injuries, especially tendinopathies.
Mm-hmm. Yeah. So with this, we're going to talk quite a bit about the functional anatomy of the forward head and forward shoulder, and then flip hats, put a different hat on, blending the two hats actually, and get into the sinew channels. So again, back to this forward head and forward shoulder. This is just one segment of what's happening with the body. You've got humeral internal rotation, and then it's going to affect the radial ulnar joint, proximal, and also distal. So there's a lot of things to be able to look at. So we're just talking about one piece of the whole here. Can we get to the next slide?
While you're doing that, Matt, it's worth mentioning that the head itself is 10 to 12 pounds. So an additional 10 pounds for every inch forward is pretty significant in terms of the amount of load that puts on the upper back and shoulder girdle and all that.
Yeah, absolutely. Absolutely. So forward head and forward shoulder is one component of something called upper cross syndrome, which Dr. Vladimir Janda was the one that coined that term. He noticed a lot of patients in this particular posture, he would document the muscle imbalances that are contributing and holding that posture as well. Now, in the 1960s, this was Vladimir Janda in the 1960s, but also Dr. George Goodhart, who's another pioneer in posture and also muscle imbalances. Both these guys actually in the 1960s talked a lot about the different types of muscle imbalances, not only in the upper cross syndrome, but also in lower cross syndrome, in the upper extremity and also the lower extremity. These two pioneers were actually the major contributors to where we actually have a lot of manual muscle testing today. And manual muscle testing is becoming much more popular than it was in the 1960s, 70s, or when I first became an acupuncturist in the 1990s. It's becoming much more popular, and these guys influenced that substantially. So it was really quite interesting too, when you look at this paragraph here, that Dr. Vladimir Janda, he thought of it as actually being more of the deficient muscle, the lengthened muscle that was perpetuating upper cross syndrome and the muscle balances. And Dr. George Goodhart was actually considering that being more of the shortened muscle is what's causing the upper cross syndrome. So interesting. Vladimir Janda thought it was more as the deficiency that made the excess, and the Dr. Goodhart thinks it's the excess that's creating the deficiency. Both work. I mean, these are both great pioneers, both actually work quite well. All right, so let's go to the next slide. So your upper cross syndrome, you've got with the forward head and the forward shoulder. If you look at the box on the upper left, short and overactive cervical extensors. So that means the upper extensors are really the biggest ones there. They're going to be short and active, the suboccipital triangle, hence the reason for causing nerve entrapment of the lesser occipital nerve or the third occipital nerve, developing trigger points when the suboccipital muscles, causing muscle tension type headaches. A whole host of different injuries can occur in that area. And then below that, you've got lengthened inhibited rhomboids, middle and lower trapezius. So those would be in a locked long position, a stretched out position. And you can see how the back shoe points of the heart and the lung here are going to be greatly affected, the pericardium as well. So that tissue is going to be in an elongated position, putting stress on those back shoe points. Then on the other side, you got your shortened and overactive pectoral. So that pectoralis minor is going to be pulling excessively on the coracoid process, inhibiting the muscles on the other side, which are the rhomboids, the middle and the lower trapezius. And then you've got your lengthened and inhibited deep neck flexors, including the middle and anterior scalene, hence the reason why you get thoracic outlet syndrome many times you see thoracic outlet syndrome with people with postures like this. Brian, do you want to say anything?
Yeah, sometimes the neck flexors, I would also include the longus coli and longus capitis, the deepest cervical flexors, which are create neck flexion, but they're a big stabilizer. And we'll get, this is a little foreshadowing, but from a sinew channel perspective, those would be part of the kidney sinew channel. So they're kind of speaks a little bit to the kidney chi and how that sort of loss of kidney chi starts to cause that depression and that dropping of the head and the forwardness of the head.
Yeah, good point. Yeah, excellent. Excellent. All right, let's go to the next slide. So we've talked about this slide before. This is some research that I did starting in 2010 and presented it, I think, in 2011 Pacific Symposium and also 2019. It's looking at different types of posture and their relation to Zong TCM patterns. So what I noticed is that with looking at from the lateral view, certain postures would come in and they would have certain types of Zong signs and symptoms. For example, the guy on the left, you got spleen, lung, and kidney deficiency, and you can see how the lungs in this position are having a difficult time expanding. The diaphragm is going to be constricted. I mentioned earlier that the tissues around the bladder, the lung and the heart back shoe points will be elongated and struggling. Let's see what else we've got. Depression of that rib cage is going to be affecting the spleen, also the liver. And in this position, the thoracolumbar fascia, the deep layers around the renal fascia, will also be restricted, inhibiting some of the kidneys. So these people themselves will often come in with spleen, lung, and kidney type of deficiencies. Brian, do you want to add anything to that?
No, I think you gave a good summary how it's not just the muscle imbalance, but how it's also affecting the internal organs and the space for the internal organs to do their proper function.
So which ones out of these 5 figures, Brian, which ones can you see have that forward head and forward shoulder type of posture?
Yeah, so the type 1, the first one is the most obvious, and especially with the plumb line, as Matt was mentioning, with the plumb line going through GB40, coming up through the greater trochanter, through the acromion, you can start seeing the shoulder going forward, and you can really see the head going forward in the type 1. The type 2 is there, but it's a little maybe obvious. It's obvious if you look at it, but with the plumb line, there's a little bit of a trick to it. And you notice how forward the greater trochanter is from the plumb line. You know, this patient in the type 2, and for that matter, the type 4 posture, have an anterior hip shift. So the hip is moved forward, and then their rib cage is starting to tilt back posterior. So in some ways, their head looks a little bit more aligned according to the plumb line, and their shoulder looks a little bit more aligned according to the plumb line. But if you were to kind of imagine tilting the rib cage back into position, you know, to kind of line their rib cage up in a straight line, you would start to see with that, you know, if you did that, how much the shoulder and the head would be forward in relationship to the rib cage. So there's definitely a big relationship between the pelvis and the head and shoulder position for those type 2 and type 4 ones in particular. But it's if you adjust it, you definitely see the forward head and the forward shoulder. So it's a little different flavor from the type 1.
Yeah, it's interesting because if you do end up changing one segment of that disparity, the compensation comes out somewhere. It's like Brian was saying, if you tilted that rib cage, or if you brought those hips back to the plumb line, actually physically did that, you would see the compensation above in the forward head and forward shoulder. That's great. Now, an increase to type 2, you look at type 4, and you can see that the greater trochanter is even farther forward, which is causing more of a posterior tilt to the rib cage, and the shoulder is posterior to the plumb line. But it's the same thing. If we brought those hips back, you would see a really far forward head and also a forward shoulder. So somebody like this could be coming in with thoracic outlet syndrome or such from the muscle imbalances within forward head and forward shoulder in upper cross syndrome. The slide 3 and type 3 and type 5, I don't see it as much, possibly type 5. What do you think, Brian?
Yeah, they're not as obvious. I mean, the head is forward on type 3, but it's really that whole body is shooting forward. So it's not as much of the obvious head and shoulder forward. Yeah, good. Excellent. All right. So then what's the next slide? Brian, do you want to take over? Yeah. And Matt, well, never mind. Your audio is a little distorted. You might want to turn your phone off, get a little extra bandwidth, but I'll be chatting here for a second and give you a moment anyways.
If I fix this.
So we kind of alluded to this in the previous slide, where we have multiple examples of a forward head and forward shoulder, but I kind of use the term flavor. You know, that the farthest one on the left, the type 1 posture, had a quote unquote different flavor than the type 2, which had that obvious posterior tilt to the rib cage and had a different interaction of how things related to each other. But ultimately, they both had a forward shoulder and forward head. So if we wanted to kind of start assessing that variation from patient to patient, one way we can start to look at is the position of the scapula, and notice that it varies from patient to patient with this forward shoulder. So a blanket term would be scapular protraction. So scapular protraction, the shoulder blades are going wider and they're usually tilting forward. But when you start breaking down from patient to patient, you can start to see that there's variation on tilts, shifts, and rotations. So just to give a quick terminology, if the shoulder blade itself moves away from the spine, we might call that protraction. It's an element of protraction, but we can be more specific and call it a lateral shift. It's shifted lateral. Retraction, it might shift medial and come closer to the spine. If it tilts forward, we would call that an anterior tilt. So in that case, the top of the shoulder blade, the SI12 region, is facing forward. It could also rotate around the rib cage, so we might call that a medial rotation because the shoulder blade's facing more medial. So just based on where it's moving, if it's moving medial, moving lateral, up, down, etc., we can call based on shifts and tilts. So we'll see an example of this on the next slide. So let's go ahead and go to the next slide. So this patient we could again call it scapular protraction on the right side, but it's different than some other people might manifest with scapular protraction. So if you look at the medial border and you were to kind of draw a line along that medial border, you'll see that the medial border comes closer to the spine as it goes inferior on the right side in particular. Notice the right side is what I'm talking about. So the whole scapula is in, we could call it downward rotation, but if we were to use this terminology of tilts and shifts, it's a lateral tilt. The top of the scapula is facing lateral. And the scapula is also moved a little bit away from the spine, so it's a lateral shift. We'd have to look from the side to see about if it's tilting forward. It probably is, so it's a likely anterior tilt. But that from this perspective is a little harder to see. But I think we will see that in the next slide. We'll get another view for a different patient.
Hey Brian, can you go back?
Yeah.
I'm sorry. Can you go back to the last slide, please? Just to keep in context what we had with the previous slide. So this would also be a medial rotation of the scapula, correct?
Medial rotation, yeah. The medial rotation, if it's going around the rib cage, we could say that's a lateral shift because it's definitely moving away from the spine. But the scapula will start following the rib cage. So you could also describe that component of a medial rotation for sure, because you can kind of picture the more it goes lateral, the more the scapula is following the sort of border of the rib cage is going to start turning and facing inward, facing medial. So yeah, I would agree, a lateral shift and a medial rotation.
So the anterior aspect of the scapula is facing medially. Okay,
medially,
cool.
Yeah.
Great.
Yeah, thanks, Matt. All right, so now to the next slide. And again, we could call this younger gentleman here, we could refer to this as scapular protraction, but it's a little different look than the previous patient. And really what you see is the strong anterior tilt. You can kind of notice that with the inferior border of the scapula, which is poking out in relationship to the top of the scapula. So it's kind of highlights a little bit more of the shortening of the pectoralis minor muscle, and the whole scapula is tilting forward. We'd have to look at him from the back. He might have a little bit of a lateral shift to the scapula. I don't recall from seeing previous images. We don't have it in this PowerPoint, but this particular patient didn't have a really obvious lateral shift, if I remember. Matt, do you remember? With
It was more of the superior shift, and anterior scapular tilt was more, but he did have scapular protraction on this right-hand side.
Yeah. But it's manifesting a little bit more as that anterior tilt. The anterior tilt component is a little bit more prominent. Well, why is this important? What's the importance of it? It starts to set a picture for which tissues are involved. And if you look at it from which muscles and which structures are shortened and which ones are lengthened, it starts to also paint a picture of which sinew channels are involved. So anything else on this one, Matt, before we...
Yeah, I think for those people that don't really know the muscles very well, is if this is the pectoralis minor image that's on the right. So you can see if those fibers shorten their attachment sites, how it's going to be pulling on that coracoid process, creating that anterior tilt. Now with an anterior tilt, the superior medial border of the scapula also raises up a little bit. So in that case, if you thought about what possible injury could be taking place here, the levator scapula, where it attaches to the superior medial border, as we know, has a lot of myofascial adhesions in that tissue, goobers basically. I mean, it just feels so very, very rough. And some people actually complain of pain in that region. So we could needle that section, and that would give good relief for a little bit. But until we actually start working on that anterior shift and the pectoralis minor shortening, we won't be able to help out the elevator scapula and have it be pain-free.
Mm-hmm.
All right,
Yeah, it's almost treating the effects, not the cause necessarily.
Mm-hmm. Mm-hmm.
Yeah, so we can go ahead and go to the next slide. So this is a little bit of a summary. So we have some scapular protractions that have more emphasis on that anterior tilt and that pec minor shortening. So we'll give you a heads up that the pectoralis minor is part of the lung sinew channel. Also, we have shortening in the upper fibers of the serratus anterior, also part of that lung sinew channel. And then that's kind of counterbalanced, especially by the lower trapezius, also the middle trapezius and rhomboids. But we'll kind of focus on the lower trapezius, which is there to stabilize against that sort of pull from the pectoralis minor that's going to pull the scapula into an anterior tilt. The lower traps are there to sort of stabilize and hold the scapula in place and keep it from being pulled forward from the pectoralis minor. So this is a very common muscle imbalance between these two internally and externally related channels, sinew channels, and muscles, where the pectoralis minor gets overactive, locks short into a shortened position, pulls the scapula into an anterior tilt, tends to pull it a little bit more into a lateral tilt, so kind of downwardly rotating the scapula, whereas the lower trapezius becomes inhibited and fails to counteract that. So we have an imbalance between these two related channels of the lung and the large intestine channel. So that's important for local treatment, but of course important for distal treatment also.
Mm-hmm. Yeah, that's great. So the distal treatment, because the pectoralis minor is going to be fascially connected to all of the myofascial tissue on that lung sinew channel, all the way down to the wrist, we can use many acupuncture points in order to change that myofascial tension. So not just treating locally, but also adjacent and distal to signal the myofascial jin what we're trying to do. So by treating the TCM Biaoli internal and external relationship here, it's pretty amazing what can happen when you soften tissue so far away and signal what you're trying to be able to do. I mean, our founding forefathers were just absolutely brilliant to be able to come up with such associations, and we're just talking about it in a different way. This is great. We will be going over acupuncture points in a little bit.
Yeah. Mm-hmm. All right, so next slide. So then this particular example now, we have a little bit more of the emphasis on the lateral shift, the movement of the scapula away from the spine. And with that, you're going to see sometimes a little less of that anterior tilt. So it speaks a little bit more to a different set of tissues, the serratus anterior, especially the middle and lower fibers of the serratus anterior, and the rhomboids. So those become imbalanced. And in the system that we teach in sports medicine acupuncture, this is part of the pericardium sinew channel. The serratus anterior is a big part of that, but the serratus anterior goes, and if you kind of notice in this illustration, it becomes a little bit faded because it's going underneath the scapula. So it goes underneath, I should say anterior to the scapula, between the scapula and the rib cage, and it attaches to the medial border of the scapula, right at the place that the rhomboids attach. So they really create one continuous myofascial sling. It's almost like it's seamed. If you can kind of picture that sling that has like a seam along that medial border of the scapula. So it's kind of anchored at that medial border of the scapula, but it's a continuous sling. And sometimes that's referred to as the rhomboserratus sling. For those who've paid attention to anatomy trains and the work of Tom Myers, he uses that terminology of the rhomboserratus sling. And we see that as a part of the pericardium sinew channel. So it's a little bit more of that influence of that channel versus the lung and large intestine sinew channel imbalance.
Yeah.
And that'll tend to cause more of an upward rotation of the scapula.
I'm sorry for interrupting, Brian. Go ahead and finish what you're saying.
No, that's it. I finished. Mm-hmm.
Okay. Hey, is my audio better now?
Yeah, much better.
Okay, good. What was I saying? Yeah, on the cadaver, it's fascinating to see the rhomboserratus sling, how the serratus anterior and the rhomboid fibers just interdigitate. It is really one tissue, like so many other tissues in the body, but just keeping in context of what we're talking about now, it's amazing to see how it's just one line of pull on that. Yeah, fantastic. Oh, also something else. Now, even though we're putting the pericardium channel or the even though we're putting the serratus anterior into pericardium and also lung, there's a gray area with that. In SMAC, we will often demonstrate that by needling the motor innervation points of the serratus anterior, for example, ribs 3 through 7 or so, you can even do 4 through 6, will change a lung pulse. So it is influencing the internal organ for sure. If you have a patient that's coming in that has asthma, common cold, a COPD, something like that, feel the pulse. If you would treat the motor entry points of the serratus anterior, that pulse will definitely get better and change. So you are influencing what's happening with those lungs. Just something to think about when you do have a patient like that.
Yeah, serratus
It
anterior.
makes sense. It's going to help the lungs to expand, the rib cage to expand by getting any kind of tension or lack of proprioception within that serratus anterior. Sorry, Brian, go ahead. What you're going to say?
Yeah, just commenting on what you're saying, that the serratus anterior definitely, when it's restricted, will stop breathing, will prevent a really good solid full inhale.
Yeah, yeah, and it's fun how fast it changes the pulse and how intuitive the body is. All right, we can just keep going on this. We better get going. We only have a couple more minutes, I think.
Yeah, so this was kind of painting a picture. It's a little bit of a simplification because things can be both. You can have both that anterior tilt and the lateral shift, but generally when you look at patients, one's more predominant, or oftentimes at least one's more predominant. And if we go back to those TCM patterns and the postures, the type 2 person that we see kind of replicated here on the right with the posterior tilted rib cage, again, if you were to tilt that rib cage back, you'd notice how much of an anterior tilt of the scapula we have here. You can see that from the illustration. She kind of resembles more of that right illustration where the rib cage is tilting back, the pelvis is shifted forward. The scapula is almost straight up and down, but if we were to adjust the rib cage, you'd see in relationship to the rib cage, in relationship to those tissues that are holding it into a particular balance, that it's a pretty strong anterior tilt of the scapula. That tends to correspond much more with kidney deficient postures. And kind of a lack of stability from the kidney channel sort of holding and stabilizing the body. That's a whole nother topic, but there's a strong correlation with this type of posture with various types of kidney deficiency that you saw from the 5 postures that Matt was highlighting earlier. So there's a relationship between the lung and the kidney channel and this type of posture. You saw it with the boy even who had that little bit of a posterior tilt to the rib cage. Versus I'm ready to go on unless you wanted to say something else about that, Matt.
I think maybe just a little bit like another demonstration that we do in SMAC to see how the pelvis in its position is related to kidney chi. We have people go ahead and stand up and partner up and feel each other's kidney pulses on the right and left hand side, and the kidney pulse is going to be the weakest. The patient or the practitioner will slowly go ahead and just do anterior and posterior pelvic tilts. Not enough to get the heart rate up, so it's going to change that pulse, but just very slowly going to an anterior and a posterior pelvic tilt, changing the fascia and the position of where the kidneys are. So then by doing that 8, 10, 12 times, the kidney pulse actually starts to come up, which is pretty amazing. And it's so significant. It happens almost every single time that this demonstration we do frequently in the SMAC program. And also, I think I did a civic symposium one time. It's pretty amazing to be able to see that. So what's the next slide?
So same idea with channel relationships, that more lateral shift of the scapula, oftentimes with a little bit of an upward rotation. But when you start seeing more of a lateral shift and that sort of rounding of the arms, that often goes and corresponds with multiple things, but especially spleen channel deficiency. And you can see with this type 1 posture, as Matt mentioned, how that's kind of compressing the spleen and the organ itself is being compressed, but the posture and the tissues associated with that posture, the tissues associated with that sinew channel are involved with the pericardium and spleen relationship. So, you might consider distal points, multiple things, but something like spleen 4, pericardium 6 might be a component of the treatment protocol for this. Doesn't have to be, but that's something that comes to my mind. Whereas the previous one, you might consider something like lung 7, kidney 6, or other kidney and lung channel points for the previous person versus a spleen and pericardium channel point for this one. So we're going to talk more about points, but just kind of think that you start making those connections now, and when we'll get into that, some point combinations.
This is great. All right, so with the pericardium and spleen, and also the kidney, the lung and large intestine relationships, the serratus anterior with the pericardium and lung, these imbalances can create a numerous amount of injuries, and we've already talked about a few. Let's go to the next slide and see what actually happens to the shoulder joint.
Yeah, so as mentioned, we could have a whole bunch of injuries that we could focus on. We talked about muscle tension headaches and spondylosis and a whole bunch of things, but we're going to kind of give an example related to the shoulder position, shoulder movement, and tendinopathies. So Matt, do you want to talk about this one?
Sure. With scapulohumeral rhythm, the humerus and also the scapula will have a rhythm as the person's going into shoulder abduction. So when you have proper muscle balancing, then that scapula will go ahead into upward rotation as the head of the humerus is coming up. Now, if there's going to be imbalance with that scapula, the lung and large intestine, that roof or the acromion right here is going to not be as strong. It will end up actually coming down into a downward rotation, abutting the head of the humerus. That particular scenario is you probably see that more times than not with shoulder problems, is the inability for the scapula to upwardly rotate and allow the head of the humerus to move freely within that joint. It's the abutting of the head of the humerus against the acromion, impinging the supraspinatus tendon, the capsule, the bicipital long head tendon, making insertional type of strains. There's so many different types of injuries that can occur with this. So balancing these muscles and the sinew channels is going to be really imperative, followed by some kind of exercise prescription, which I believe it was last month or the month before that Brian and I had on one of these AAC podcasts, right, that we talked about this.
Yeah,
Brian,
both.
did I leave anything out?
No, I said both. We talked about that last two webinars, I believe.
Yeah. You know, it's interesting too with this, because we don't have very much time left, is that we talked about mostly what's happening with the scapula, but that head of the humerus with a forward shoulder position. In fact, you can just do this yourself. If you sit up and you have your shoulder go forward, your humerus starts to internally rotate, and that's just the way that it starts to move, causing more muscle imbalance within the rotator cuff, between the heart and the small intestine Jingjian. So it just keeps on going. We just don't have enough time in this 30 minutes to be able to talk about all that. So let's go to Brian, anything else? Go to the next slide.
No, I think that's good.
All right, so this is a severe case of shoulder impingement syndrome, but you can see in this x-ray as the person's going into shoulder abduction, the rotator cuff muscles are not pulling that head of the humerus down into the joint, and it looks like the scapula stabilizers, the lung and large intestine Jingjian, and also the pericardium are not lifting that scapula properly into upward rotation. The greater tubercle of that humerus is hitting the acromion, and in fact, it looks like it's been doing it for an awfully long time, because you can see at the superior aspect of the humerus, like a rough mountain range edge there. I don't know if you can see that. I don't have a cursor for that. I can be able to do this, but at the very top of that humerus in the black, you see a very rough edge, and it looks like that's probably from necrotic tissue or a lot of overuse banging into the acromion. This person was in some pain for quite a long time. Let's talk about some acupuncture points that we can use for forward head and forward shoulder. Brian, what do you think?
Yep, sounds good.
Next slide, please.
All right.
So go ahead, Brian. Why don't you start off?
Go ahead.
So the local points are going to be based on the particular injury, obviously. So is it going to be periscapular pain? Is it going to be levator scapula insertional pain? Will it end up being supraspinatus tendinopathy or maybe bicipital tendinopathy? So depending on which injury is going to predicate what local points that you have. Now the adjacent points, we want to needle the Wato-Jaji points bilaterally. That's going to be level with the innervated tissue. So needling C4 through C6, which the C is not on there. My bad. Sorry, guys. So the Wato-Jaji points of C4 through C6, needling the pectoralis minor motor point, motor entry point, which would be best if you were actually shown how to be able to do that, so we don't create a pneumothorax if you've never done it before. The rhomboids, the middle and the lower trapezius motor entry points would be good to get that communication between the pectoralis minor and the trapezius. And of course, the serratus anterior ribs 3 through 7, another muscle that would be best shown how to be able to needle those motor entry points, because if you, obvious reasons, if you don't actually needle that muscle and go into the intercostal space, you could cause some damage with that. So if you're unfamiliar with the anatomy very well, you don't want to needle these motor entry points unless you're shown.
Yeah. And Matt, just
And then
to be
Brian,
clear, it's not 3 through 7 like all of them. You wouldn't be needling serratus anteriors, rib 3, rib 4, rib 5. So you're picking the more restricted 1 or 2 regions, you know, of slips of those serratus anterior. That'd be a lot of needling for, you know, for all of those slips.
True. But we are needling 2 to 3, sometimes 4, depending on the case.
And the person's chi and all of that.
You want to cover the distal points, Brian?
Yeah, so flexor carpi radialis motor point is a really excellent motor point or motor entry point that will soften the pectoralis minor. So in combination is great, but if you're not comfortable with needling the pectoralis minor, it is good to learn that in a classroom setting, just so you do it safely and don't cause damage to people. But the flexor carpi radialis is a little bit easier of a tissue to work with if you haven't been trained to do pec minor. So it's going to have an effect on pec minor for sure. Other points along the lung and large intestine channel would be indicated. Li6 would be the chi cleft point of the large intestine channel would be really useful. Lung 7 would be an excellent point. Brachioradialis is kind of associated with both lung and large intestine, but it's definitely a large intestine channel point that's going to influence that portion of the channel. Pronator teres motor point would be more for pericardium sinew channel. So if it has more of that lateral shift, and again, serratus anterior is difficult to needle for some people if they haven't been trained. Pronator teres would be a really excellent, in addition, or just needling that one as part of a comprehensive treatment would be good. And then P6 for obviously for the pericardium channel.
Yeah, it doesn't have to be all these points, you guys. It's just, we're just giving you some points to be able to choose from. The brachioradialis motor entry points, we could do large intestine 11, that can connect large intestine and lung. That's the upper point. And then lung 6, the chi cleft point, is also going to be a motor entry point for the brachioradialis. So points that you can be able to use to be able to communicate up or into the Jingjin. Just to geek out a little bit more, when you were talking about the flexor carpi radialis, my mind went to that cadaver dissection that we did on the last specimen. So thank you very much for this donor, continuing to help us learn quite a bit. How you showed the really strong connection between the biceps and the flexor carpi radialis, you know, for that lung sinew. I thought it was fantastic. It was great.
Yeah. Just briefly, I don't have time to go into it, but the connection is the muscle itself attaches flexor carpi ulnaris, flexor carpi radialis attaches to the medial epicondyle. Definitely not on the lung channel distribution, but it has a fibrotic structure from the biceps called the lacertus fibrosus. Sometimes it's called the bicipital aponeurosis that links the flexor carpi ulnaris with the biceps, which is part of the lung sinew channel, and then from there, short head into the pectoralis minor. Yeah, it's a really strong link.
So we talked about how the rhomboserratus sling, how the rhomboids will interdigitate also here with the serratus anterior. When you look at the cadaver specimen, you'll see the pectoralis minor come up to the coracoid process and just fascially bind right with that bicep, also the bicep short head. So it's just one continuous tissue onto that coracoid process. It's fascinating to see the connections in the same layers. Anyway, so we're geeking out on that, which is great. So should we get into a video? You want to introduce the video, Brian, of the myofascial release, what we're doing here?
Yeah, sure. So this is a pectoralis minor stretch. It's a pretty simple technique. You can do it with the person in a prone position, and the video will walk you through it. Really good to do after treatment. I guess you can make an argument if you're doing face down treatment and then turning the person over and doing face up treatment, that you might do it in the after you take the needles out from the face down position and before you turn them over. But generally speaking, we teach these to do after treatment. So the video should run through everything. So we'll go ahead and go into the next slide.
So with this technique, it's a passive stretch of the pectoralis minor. You're going to use both hands. One hand covering the scapula, especially covering the inferior angle of the scapula. The other hand reaches underneath and hooks around the coracoid process. So you have to have contact with the coracoid process, and you're following to the inferior border of the coracoid process. So with the one hand pushing down, kind of in a direction following the lower trapezius, it's almost like you want your hands to be the lower trapezius in terms of function, by pushing the scapula inferior angle down and lifting at the coracoid process to give a stretch to the pectoralis minor. When I say lifting, I'm not lifting straight up. That's going to lock the scapula and kind of limit movement. But lifting is really more, in some ways, following the angle of the lower trapezius and lifting headward, cranial, and slightly towards the ceiling while you press the other hand down. And you want to picture the fibers of the pectoralis minor getting longer. And you can hold for however long you feel is appropriate. You can change the angle slightly to get different fibers. Pec minor has a third, fourth, and fifth rib attachment, so different angles will get different fibers of the pec minor.
Yeah, so the video is longer than the technique needs to be just because it was showing the setup. It's kind of a subtle technique. If you don't have the right line of pull, you don't get as much benefit from it.
Yeah, and feels so good when that technique is applied. That technique is great in a combination of acupuncture, myofascial work, and then doing the stretch. It really helps with the forward shoulder quite a bit. But that forward shoulder is going to go right back into place if the person goes back to their desk and doesn't do their exercises, do the opposite movement and a host of different movements that can be able to help open up that chest. Mm-hmm. Well, Brian, is there anything else that you want to say? We've gone over our time again. Thank you very much for hanging in there, you guys. I hope this was useful for you. Brian, anything else that you want to be able to say?
No. I think the technique is, you'll see if you wanted to reference that in recordings. That is going to be one of the techniques that we're going to have in a upcoming class. That'll be a webinar in March. So we'll have a lot of different techniques like that, and kind of combining some myofascial release with acupuncture.
Awesome, cool. So I want to thank American Acupuncture Council again. Thank you, Brian. It's always nice hanging out and doing these things with you. Next week, Sam Collins is coming in to be able to discuss the billing and coding for insurance. He's always great for providing the latest updates, which is really important in these ever-changing times. So thanks again, everybody. Really appreciate it. And we'll see you again next month. All right.
Yeah,
bye-bye now.